Well, hi everyone, it's Pete here again for the Pain Toolkit, and yes, we are back on doing another Pain Toolkit Academy Q&A. And yes, got Dave here with me. Good evening to you, Dave.
Sorry, I'm on mute. Good evening, Pete. How you
It's all
seeing?
right. And we've got another guest with us tonight. This is Asim, he's a GP from the Bradford area. Good evening to you, Asim.
Good evening, Pete, and good evening, Dave.
Yeah.
Thanks for inviting me onto the
Hope
question and
you,
answer session.
so I hope you've had a good day today. Have you seen many people today with pain, Asim?
Yeah, I've seen a couple with pain, and I've also done some occupational medicine as well. So
Right.
a pretty varied day today.
Okay. So can you just introduce yourself to the viewers and
Yeah, sure.
just a brief outline of what you do, etc.
Yeah, so I was born and bred in Bradford, and went to study in Liverpool. Graduated there 25 years ago, in fact, 25 years this August.
Yeah,
um, and started work. Gradually kind of drifted towards general practice, and that's where I kind of my interest started to peak with regards to the amount of people I was seeing with chronic pain. So decided to just do a master's in pain management, and then kind of developed my own pain service in Bradford. Um, so that's what I do kind of part of the week. I'm a general practitioner for part of the week and then do some occupational medicine as well. So looking at that interface between work and health, and you see a lot of chronic pain in occupational medicine as well, unfortunately.
yeah. Unfortunately, I think the British Pain Society
Yeah,
they're still quoting 28 million people in the UK living with pain. So I know globally that.
yeah, no,
Yeah,
absolutely. Yeah, and I think from a sickness absence point of view, just as a side note, I guess, Pete, the two most common conditions are musculoskeletal
yeah,
pain, and kind of mild to moderate mental health. Those are the two most common causes of sickness absence, and it's a huge problem, really. And it massively impacts not only obviously on people in pain, but on employers and wider society. And yeah, perhaps um, something needs to be done about it slowly but surely.
yeah. It's I know IASP and the World Health Organization they're still quoting not one in five people globally now living with persistent pain, and but I think the good work that you do there in your area, and I think there's just a problem really. Only seems to be pockets of goodness around.
Yeah,
Lots of good, people, good
yeah. So
GPs
yeah.
like yourself, and
Yeah, so I started in kind of doing it about 15 years ago, and really there was only kind of one or two areas perhaps in the UK
mm,
where there was good amount of activity, good quality kind of pain management going on. But I think fortunately, and it's good to know actually, through various reasons,
mm,
pain management is kind of spread throughout the United Kingdom.
yeah,
Whether it's through, well, kind of through yourself, paintoolkit.org, whether it's other people like Flipping Pain, Live Well with Pain, and the own service that I set up in Bradford called Rethinking Pain as well.
yeah, yeah,
And now it seems that everyone is networking and everyone's kind of working together to kind of push forward,
mm,
good pain management, and particularly focusing on self-care and self-management as well.
yeah. Okay, right. Let's get cracking with the questions. We've got a couple from healthcare professionals and a couple from people
Sure.
with pain. So the first one is from a healthcare professional called June. She said, "Can you discuss the role of a general practitioner in a multidisciplinary approach to managing persistent pain?"
Yeah,
Uh,
no, sure.
yeah,
Good question, really. Yeah.
mm, mm,
A really important question as well. So I think historically, general practitioners have played what we seem like a gatekeeper role for kind of the health service. So way back it was formed for over 70 years ago. And we've kind of kept in that role. And from a kind of pain management perspective, GPs often serve as a first point of contact. And we're still at that kind of gatekeeping role, but we've also become almost like coordinators of care. And that's where I see the general practitioner's role, and also perhaps like someone like myself with the interest in chronic pain and pain management, persistent pain. we are acting as coordinators, and that's where we're able to kind of coordinate care between specialists such as physiotherapists, social prescribers, secondary care pain management teams, persistent pain rehabilitation teams. And that's one of the roles that I think is quite
Mm.
defining for a general practitioner, and particularly one with an interest. We also perhaps are starting to focus a lot more on the biopsychosocial model of care. And that's changed somewhat. So when I first started some 15 years ago in pain management, it's really shifted from the biomedical model of care to the biopsychosocial model of care. Yeah, so
Mm.
that's obviously looking at the medical history, but focusing really on the mental aspects of being in chronic pain, but also the social determinants of
Mm.
pain,
Mm.
a person's education, their background, their employment comes into it, attainment levels, etc., etc. And there's definitely a shift now more towards the biopsychosocial model of pain, and a move away from the biomedical model of pain. Another aspect of perhaps the GP's role is looking at things like medication, and what we term stewardship. So there's a term that we often use for antibiotics called antibiotic stewardship, where we're trying to reduce antibiotic usage in the general population.
Mm.
Similar thing, particularly since the NICE guidelines came out a couple of years ago, we're starting to move away from kind of prescribing, or inappropriate prescribing, I should say, and kind of help people perhaps manage their pain better rather than focusing on medications as a solution. And fundamentally, one of the other major roles of a GP is that patient advocacy role, because navigating the healthcare system can be very difficult, and having access to kind of multidisciplinary care is vitally important. And I see kind of GPs kind of having that role bang in the middle there to try and coordinate the care between different healthcare professionals,
Can I ask you
as managing. Yeah, sure. Sorry,
yeah,
Pete.
can
I'm
I ask
talking.
you,
I could talk forever.
I just want to, do you think, when I talk to, I was speaking to GPs over the years, they say, yeah, this is great. When I've done, you know, presentations to GPs and allied healthcare professionals, and
Yeah.
a lot of them say, yeah, this is fantastic. This is
Mm.
good stuff. Well, you ain't got the time to do it though, mate. And do you find that at time as an issue with yourself, like,
Yeah. So
with patients?
I think with my kind of, yeah, with my standard kind of GP hat on, time is of the essence here. I mean, they used to say perhaps you have 7 minutes. It's probably just slightly over 7 minutes, maybe 10 minutes. And those extra 3 minutes can be vital. However, that is such a short amount of time, because
Mm.
what you're asking GPs perhaps to do in that time is um, listen to someone, perhaps diagnose them, and then put a management plan together.
Mm.
And that is not a massive amount of time. Now, what's happened over the years perhaps is specialisms, like for myself, have come into play. So I kind of sit above primary care, but just under secondary care, so the hospitals.
Mm.
And at those places, perhaps at musculoskeletal teams, where a lot of the people who have persistent pain have probably been referred to, you do have a little bit more time. So you're talking 20 minutes, sometimes 30
Mm.
minutes, sometimes slightly longer. And that allows people to have a lot more time to just listen to people, essentially. And I'm a great believer in listening to someone and their story
Mm. Mm.
unfold in front of you, and then you can help them manage their story and help them manage their pain
I don't
better.
know. I don't know if this is
So yeah.
I don't know if this is a good an idea. It's just, I mean, I've the surgeries I've been to over the years, sort of thing.
Mm.
They always have like specialist nurses there. Like in my surgery, there's an asthma nurse,
Yeah.
um, and I mean, it might be, might be a bit too rock and roll for a lot of the decision makers, but
Yeah.
but would it be useful as there's, because I always remember talking to when I first went and started going to my surgery about 10 or so years ago, and I said to the GP, I was down there for something, I can't remember, and I said, do you see many people with long-term pain? And he just sat back in his chair and laughed. He said, yeah, every other person, like, if they've got some sort of pain issue.
Yeah.
And I'm thinking, as it's so prevalent, would it be useful if a surgery had like a dedicated, like
Well,
like an asthma nurse,
yeah,
or perhaps there could be at least be a persistent pain coach or something like that. I mean, is that too? Is that?
absolutely. And that is slowly happening. Again, one of the benefits of primary care, even if perhaps you have a short amount of time or it's only a telephone consultation, you often have that continuity with patients.
Mm,
So you can talk to them perhaps 1 week and you can follow them up 2 weeks later.
mm,
And often that interaction with patients on a regular basis can be as good as perhaps a consultation in secondary care, one-off secondary care consultation, perhaps. What's also happening in primary care is primary care team is getting bigger. So not only do you have general practitioners, which were kind of the bedrock of general practice back in the day, now you have advanced nurse practitioners, you've got physicians associates in places, you've got social prescribers
yeah.
and pharmacists, everyone who can interact with a patient. If they do get the training, which is something we do up in Bradford, so you can train them to start to understand basic pain neuroscience. They can start to help manage patients, like you're suggesting, Pete. Absolutely, we can guide them, we can signpost them, we can listen to them empathically. We do that, and we train up enough people, then everyone who has an interaction with someone who's in persistent pain makes it an absolutely invaluable experience. Really.
Okay, thanks. Have you got anything to add at all, David? No?
No, no, it's really interesting listening to you. It's so great to hear that there is that intermediate level between the GP and the hospital.
Yeah.
Yeah. Yeah, most musculoskeletal teams do have someone who specializes in pain. There will be pockets where that might not happen, and that's but if it's definitely the awareness is increasing not only in doctors but physiotherapists who perhaps manage pain, and then obviously psychologists as well. And it's interesting because what we try and do is we try and train people in the West Yorkshire area to have little bits of kind of uh, interventions in their kind of armory. So a physiotherapist might use a bit of psychology, might use a bit of neuroscience. The social prescriber might use a bit of
Mm.
pharmacy to understand someone's pain medications. And so everyone does a little bit, but everyone's kind of, as the saying goes, singing off the same hymn sheet. And if we do that and we scale it up across the country, I think we'll be in a much better place really to help people who are struggling with their pain.
Okay. Um, it's work in progress, as they say.
Yes,
I,
yes,
I,
it has to, yeah,
I
absolutely.
always think
But we are making good progress, I think.
yeah, I think you guys in the north are doing more than they're doing down here. Like, it's like a little in some areas down there. So I talked to a few people down in the south, like GPs and other providers. Like, it's a bit vague, what's going on. And but
Mm,
I think yourself, Tim Williams and Ollie Hart up there in Sheffield. I think
yeah, up in Sheffield, yeah.
they're doing a fantastic job there. They've been doing that for many years now. And so,
Yeah.
anyway, it's only my observation. If I apologise to anybody in the south,
Yeah, no, absolutely.
say, no, hang on a minute, what are you talking about? Okay, we got another question from a healthcare professional called Adam. And what are the common challenges do you face in diagnosing and managing patients with persistent pain, and how do you address them?
Yeah. Another really good question. Another good question. So I think one of the issues that I've experienced over the years, and it's less of an issue for myself now, but probably still an issue for lots of healthcare professionals in primary care, is that pain is subjective. Now, it sounds silly saying that, doesn't it? But um, doctors and healthcare professionals like things clear cut and objective.
Mm,
So if someone presents with a condition, they like to examine them, they like to diagnose them, they like to investigate them with a blood test, a scan, a urine dipstick, for example. Now, with pain, that is different because it's essentially a subjective experience,
mm,
and there's still no no objective test, although obviously research is ongoing to functional MRI scans and so forth. So we know pain, people are experiencing pain, but at the moment there is no subjective test. And that unfortunately can lead to people being dismissed by healthcare professionals in primary care. You touched on the time issue. Um, I've had patients come to me in my pain service and say, the doctor I spoke to the other day just still doesn't believe that I'm in pain,
Yeah.
and that still happens, unfortunately. Again, it is changing with education, but yeah, it's still kind of a bit of a stigma, perhaps with pain because there is no objective test. Now, the question is obviously how we move past that, and I think it's a combination of education, primarily for clinicians and healthcare professionals, but also for patients as well, and what perhaps we can help patients do. So what I often talk to patients in clinic and say, perhaps you could take like a diary, pain diary with you. That can be really useful for a GP um, to try and understand what's going on in your life. Trying to talk about the impact it's having on your function, on your day-to-day life, in relationships, in work. Again, that has a lot more of a kind of emotional impact on clinicians.
Yeah.
Talking, sorry, Pete.
No, I
I
was
was
going
going
to
to
say,
say,
I remember, as you're saying, really, Asim, it's once you've had, once we've had pain for longer than 3 months, like, it's all the other stuff kicks in, It's little slide I use one of my presentations, like the iceberg, because
mm,
with the
yeah,
after 3 months, all the with it's just that pain is just the tip of the iceberg, and all the other things kick in.
absolutely. It's everything else going on underneath. Yeah.
Yeah, all the social problems and whatnot, or perhaps they're getting some hassle from work and relationship
Mm.
problems and all that super. In the end, it actually supersedes the pain itself, like And I think, as you mentioned in the last answer to the question, I think that's where I'm a big fan of social prescribing, because I think they can
Yeah.
they can be a useful asset for you guys, like to support you along the way. Because again, so it comes back to time restraints and stuff like that. And myself and Dave know, like we both live with pain, and we know we're tricky customers, like Um, and I think we Dave,
No, no, absolutely.
when we look back at
Yeah, I
back in
think,
the early days, like when it wasn't quite on Christmas card terms with me GP, but I was certainly one of those, the frequent flyers or
yeah,
we
I
walked
don't
up.
know. Yeah, don't know whether you'd experienced this, Pete. But one of the other things I often sometimes see is over reliance on medications, but also
Yeah,
over reliance on healthcare professionals.
yeah,
Um,
yeah, yeah,
because pain can be so overwhelming,
yeah,
often that
yeah,
people are crying out for help and support,
mm,
really, and that can be quite challenging, and that takes time
yeah,
um, to start at the basics about pain neuroscience, pain understanding, using your skills as a GP, as a doctor, as a clinician to listen empathically, reflective listening, and just explaining. And that's one of the things that perhaps some of the other healthcare professionals in primary care have. They have a little bit more time, so they can listen to patients. And often patients just want to tell their story, and you can learn so much from just listening.
yeah, yeah,
And
yeah,
once they've got it off their chest, so to speak, they can often start kind of asking for help to how they manage their pain a bit better,
yeah.
really. But I guess sometimes they've got to be in the right place, really, and it's catching them in that sweet point, really, to try and help and support
Exactly.
them.
Exactly. Like, yeah, when I call it becoming sick and tired of being sick and tired. Where they,
Yeah,
where,
until something
where,
switches, perhaps. Yeah.
yeah, and I think it's where like people like myself, Dave, and all the other self managers around, where we can, because when I was worked on the NHS expert patients program years ago, the magic about that program was when we was running the courses, everybody who was running the courses were living with long term
Mm,
conditions. So no one in the audience, none of the participants could say, you don't know what it's like to live with blah, 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 And we say, oh, well, actually, yeah, we do,
Yeah.
so we know their struggles sort of thing, so that's where I think, I don't know what you want to call us, lay coaches and stuff like that, where we
Mm,
might have where we can support you guys, because listen, man, I've got some really good GP buddy friends, and I know a tough job you've got, and as myself and Dave, we've been working the other side of the counter, we know how that can be
yeah.
frustrating for you guys, and that's why, us, we want to work with you guys. How can we help you guys a bit more? And that's why we come up with doing developing the academy, like the Pain Toolkit Academy, so that
Yeah. And it's amazing.
it fills that little bit of a gap there, where because we were talking to Linda last night from over there in Denver, and so they don't. She said openly, she said they don't get the training within their respective medical schools, for about self management, etc. So it's
It's
about
very little, if any, actually.
say again.
I get very little kind of education
Yeah,
about
yeah, yeah.
self-care and
So
self-management, if at all. And
yeah,
I've learned most of it since graduating, if that makes sense.
yeah.
And the importance of it, absolutely vital.
Yeah, and
Yeah.
also the conferences that we do, uh,
Mm,
the self-management conferences that we do, the European one we got coming up on the 18th of October. They again, it's the healthcare professionals and self-managers. It's all about, we can't do this all on our own. We've got to all work together as a team, sort of thing. Okay,
Mhm. Yeah, I've got a follow up
absolutely.
to something you said. You were talking about catching the people, the patients at the right time when they're ready to hear about it. Have you worked out any way of speeding up that process for people where you realize that, the medication's not going to do a lot for them long term and they need to move on to something else? Because it's something that held me back for about 6 years or so before I came along to the Pain Toolkit. And I'm just curious if you've got any tips and tricks to speed that process up.
Um, yeah, I mean, it's a really difficult one because I hate to state the obvious, but everyone is different,
Hmm.
and everyone comes to um, clinic, so to speak, with their own ideas and expectations. Um, and also everything they've experienced from the NHS or private providers since they've been on their pain journey. And often because I have a bit more time in my clinics, I can just sit and listen essentially for the first 5 to 10 minutes. And then I can kind of try and home in on what's important to them. And I often send them a pre-appointment kind of questionnaire. And that starts to get them to think about what's their expectation from me and what's the expectation from the consultation. So before the consultation has even happened, they're already starting to think about what outcome that they want from this
Hmm.
interaction with this doctor. And my experience is once I've spoken to them in clinic and perhaps examined them and started to just get a feeling of where they are along that pain journey and how confident they are to self-care and self-manage, um, I can then start to try and work out how we're going to help. And
mm,
it's not. I often say to them, my job here is to help you manage your pain better. And often I get a bit of a quizzical look, saying, "What do you mean, doctor? You're meant to help me?" And I said, "Well, I'm going to see you for 20 minutes. I might not ever see you again, and therefore." How can I best help you? What is your expectation? And how can I help you manage your pain better? And often that can be a bit of a light bulb moment because no one's ever said that to them before.
yeah,
Um, and obviously I use different techniques for different people depending on whereabouts they are on their pain journey.
Hmm.
But often just sometimes stating the obvious, uh, uh, you know, I don't often sound patronizing to my patients and I never want to ever come across as that. But I often say to them some things like, you've had your pain now for 10 years. Doctors don't hide cures from you. You know, I'm
Hmm.
not going to reach into my cupboard down here and here's a magic cure to you. Honestly, we're not, the NHS is not like that. Um, so I turned the question around to them and asked them, how do you think I can help you? And and that often kind of opens up a whole host of conversations about basic pain neuroscience, the interaction of mental health in chronic pain. Past trauma comes into it. That's really common. And you can open sometimes up a bit of a Pandora's box, really. So you got to be in the right place. And if I do feel I've started to make inroads with someone, I can bring them back a couple of weeks later once I've given them some information, signposted them, perhaps talk to them about a condition. And then when I bring them back, I can often have a conversation to say, how ready are you for perhaps a community support program, a pain rehabilitation program, or they might not be ready at that moment in time and might not be happy to go down that route, in which case that's fine.
Mm.
Here's some information, we can support you, and then you can always get a referral back at some point.
Nice.
I always remember a slide I saw from the Department of Health years ago, and I've often used it in
Yeah,
presentations. Is that it said I think they worked out that someone with a pain or a long-term condition will only see a healthcare professional for 3 hours in a year, and
yeah, exactly.
I think also to people with pain that. So what are you going to do for the other 8,757 hours, like or whatever it is, like. So that's
Yeah,
where you need to do that bit, and it's I think some as you call it the light bulb moment, and that honesty really that
yeah,
thing is. I think for a lot of people they are self-managed. They say self-management is not or I would call a street word. It's a fairly new,
mm,
and a lot of people won't know what that means. Some people think, well, you got to go off and do your own thing, but it won't.
yeah,
It's not so. It's that it's about that coming back to that teamwork thing. Look, Mrs. Smith, this is what I can do, but now let's have a look at what you're going to be doing, so they
yeah.
have a teamwork contract, etc.
I often have you heard of motivational interviewing, Pete, Dave?
Yeah,
Have you?
yeah, 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 yeah.
Yeah, I tend to use that a little bit actually, and I try and gauge
Sure.
the importance
Yeah,
of someone's change, and also obviously the confidence. How confident are they? And then I tend to work on either one or the other, if
yeah,
that makes sense.
yeah, good, yeah,
Or
excellent.
sometimes they don't need that much help and support. You
Yeah,
can just kind of push them in the right
yeah,
direction.
yeah,
So I find motivation interviewing really useful for all types of chronic
yeah,
diseases,
yeah,
and particularly in pain as well.
good. Okay, we've got a couple of from people with pain now. Maureen asked, for people living with persistent pain, what key advice do you have regarding communication with their
Mm.
GP to ensure a comprehensive pain management plan? I think you've pretty much gone through that already, haven't you?
Yeah,
Yeah, I think you've. So
yeah.
there's nothing really to
I
say.
think I think key is to keep information, keep a diary or keep some notes on your phone about how you are, what when you have exacerbations, perhaps, or if you've noticed that you're doing too much, and if you've done an activity and you're shattered, keeping it like almost like a pain diary, obviously, that's really helpful for healthcare professionals because they can actually see it and visualize it.
Hmm.
And I often use diagrams and anatomy diagrams and talking about different types of pain and colors and so forth. That's really useful.
Yeah,
I think also about and this is a really hard one. It's having a realistic goal, and because patients perhaps are still and people in pain are still wanting completely understandable, still wanting cures and solutions and so forth. And um, we will try our best as healthcare professionals. Um, but sometimes the realization is that there is no cure to this, and
yeah,
it's how we help patients to a degree of
yeah,
acceptance, and that's really hard and challenging at
Hmm.
times. And
yeah,
that's a perhaps a topic for a different question and
yeah,
answer session at some point. How do we deal with acceptance,
yeah,
and not only from obviously the people in pain, but also from the clinician that
yeah,
we are human, and we have our limitations as healthcare
yeah.
professionals as well.
It's we call it like having an unwanted passenger in our life, and it's how we need to learn to get on with each other, like. myself, Dave, and other self-managers, we know
Mm.
for us to have some sort of good quality of life, we know we need to be doing some self-management stuff, keeping active for stretching, exercising, whatever, whatever we use, so that we can get on with, live our lives to the best, like, but we can't, as you say, like there isn't. I've never met anybody
Yeah.
ever a magic cure or whatever. I know there's plenty of people out there who's, oh, you need to be doing this or having this therapy, that therapy. Well, if
Yeah.
I've done a lot of research. I mean, I spent £8,000 back in the day, and anybody with an history or
Oh,
knowledge
wow.
their name,
Yeah.
to my knowledge,
Yeah,
there ain't one.
yeah,
Yeah.
but we're talking decades ago, so that £8,000 was a lot back then.
Oh yeah,
True.
I looked it up
Probably
the other
about
week.
50K equivalent.
Yeah, I don't know. I looked it up the other week. I know it's monster money, but that was back in the early 90s. That was. Anyway,
Yeah.
listen, no, no, we've got Jerry's got.
But I like the
Oh,
I like
sorry.
the diary and I like the goals.
Yeah,
Mm.
They were the things that finally got me going down the journey.
yeah.
Yeah.
It's a purpose. It gives us purpose, doesn't it, Dave?
Yeah.
It's sort of
Absolutely. Yeah. Yeah.
we got
And
a thing
humans, yeah,
in the later part.
human behavior, really go with targets, don't they, as well?
Yeah,
And the achievement feeling as well. Absolutely.
in the later editions of the pain toolkit, we put together something like "How Am I Today," and it's
Mm.
like the pain cycle that's in the pain toolkit. But how am I today? And it's a simple guide that they can mark off, and they can keep a track of uh, not their pain, but how they are, and
Mm.
they see how they're doing, and also they can show it to their to people like yourself. So I know we're all
Brilliant.
us lot. I don't know about you, Dave. I'm very visual. A lot of people with pain were very visual learners. You know, I don't know. I don't know what. I think our attention span is pretty. Ain't it? Especially if you've got just sort of getting into the self management stuff, like sort of pain still
Mm.
trying to grab your attention and stuff. So. But keeping it simple and being visual. I think I found
Absolutely.
when I worked on the expert patients program, I found people with other long-term conditions, they are as well, like, so um, yeah, anyway, I'm going on
Yeah.
in myself here. uh,
So,
Here we go. Last one of the second to last bit about from Jerry. What lifestyle modifications or self-management strategies do you believe can significantly impact a patient's experience of persistent pain? What sort of modifications?
yeah. So yeah. Very again, really common kind of towards the end of a consultation. I often get this question from patients, and so what can I do, doctor? I often say the first thing I say, um, movement is absolutely key. Yeah. Um, but find an activity that you like doing and something that you can persevere at, because that is most likely to give you the benefit in the long term.
Hmm.
So the research for physical activity is immense now, absolutely, not only for physical health, but obviously for mental health
Yeah,
as well.
yeah, yeah,
So movement is great. And I often say to patients, do three things well and you should be okay. So you move well, sleep well, and eat well. Okay, sleep is absolutely vital. I think we underestimate how important sleep is. The old saying is we spend a third of our lives asleep. But if you don't get that refreshing, regenerative sleep,
yeah.
that can impact on how we are mentally and physically as well. So I'm also doing a lot of work with kind of sleep, and there are some new medications and some new techniques now to help with those patients who are in pain. So it's one of the few questions I often ask, kind of, how is your sleep, and how does it impact upon you when you don't sleep well? And I would say 95% of my patients in pain, people in pain, have sleep problems,
Yeah.
and it's often neglected in the consultation, but I try and focus on it a lot. And then good gut health, and there's lots of evidence now to suggest that a good, healthy, balanced diet um, is good for your health. It's good for your gut health, good for your physical health, good for your mental health because of the microbiome, and there's lots of evidence coming out. And I think, I don't know if you've ever had Deepak Ravindran on these chats,
Not yet.
but he's
Not
doing a
yet.
lot of work. Yeah,
Not yet.
not yet, but he's doing a lot of work looking at kind of the neuroimmunology aspect of, having a good balanced diet and what impact that has on pain. Um, and then just pacing. Pacing is absolutely vital. People in pain, for whatever reason, and you were probably at this point at one stage or the other, both of you, Dave and Pete, where people were over pacers.
Yeah. Oh, yeah.
And yeah, and and I guess it's just trying to explain to people who might be new to the concept of pacing what it is and how we help
Yeah.
people manage and
Yeah. Well,
pace better. And then just making sure, last thing would be social support. As human beings, we like social interactions, whether it's football, and I know you're an Arsenal supporter, Pete, but I'm a Liverpool
oh,
supporter, so
so's Dave.
yeah.
And Dave's a gooner.
Liverpool.
Oh,
Oh,
The proper team, the proper red team.
So whether it's going to football matches, dance clubs, doing stuff in groups, tough mudders. So get yourself into a group, arts and craft group, singing, choir, dance, anything. And there's lots of things becoming available now related to pain and kind of self-help groups and self-management groups. We're doing in Bradford. We kind of set up a faith group. We set up a dance group. We set up an arts and craft group, and that coming together of people who have pain talking to each other peer to peer has been absolutely invaluable, and that in itself can help the pain
Yeah.
drop eventually down.
But-
So yeah, those are my.
Yeah. So you mentioned that 90 to
tips.
95% of your patients have
What
sleep.
what helped you guys?
Sorry, yeah. You mentioned 90 to
I would say
95.
absolutely, yeah.
Yeah. You mentioned 90 to 95%
Yeah.
of patients have sleep problems. What are the other 5 to 10% doing that's different? Is there anything common between them, or
And
don't you sort of dig into that because they're okay, so you move on to something else?
the ones who are okay are usually um their sleep hygiene is absolutely immaculate, if that makes
Okay.
sense. And they may use sleeping aids occasionally, but they make sure they're absolutely exhausted. They go to bed at the right time, at the right temperature. They switch down, they reduce their screen times. And they're often kind of involved with, because one of the treatments and therapies for sleep, which has been proved to be evidence-based, is cognitive behavior therapy
Hmm.
for insomnia, and that's recommended by NICE as well. And there are some medications which can help, things like melatonin and the old school medications of amitriptyline, but unfortunately have a lot of side effects. But there are one or two other medications that are coming on board. Um, but so those people who are good sleepers tend to have fantastic and absolutely immaculate sleep hygiene. And that's the first kind of steps I often talk about with patients. What's your sleep hygiene like? Um, Tell me about a typical night. What happens? And then you can try and work out what kind of sleep problem they may have,
Hmm.
whether it's at the start of the night, whether it's during the middle of the night, whether they're lacking certain amounts of REM sleep, the regenerative sleep, etc., etc. So it can become quite a deep subject, actually, but I do feel it's neglected, and that's something I'm trying to focus on as well.
Well, you'd be pleased to hear I think, is it Nick, on the 18th, Dave, we got Dr. Sue Peacock. She's a counselling psychologist,
Okay.
but she specialises in sleep. So we can grill her a bit more about the sleep stuff then, like,
Yeah.
you know.
Absolutely. Yeah, really
Yeah.
important.
Okay, last question, and you can get on with your evening. This is a
Yeah.
lot of question we've been asking everyone now, actually.
Okay.
Great. It's still nice. It sort of rounds it off, etc. So imagine you could host a dinner party with three prominent figures in healthcare. Who would you invite, and what would you discuss regarding self-management?
Okay. I'll give the easy answer first. I think it would be. I'm just going to say the Secretary of State for Healthcare. Yeah.
Oh, yeah. Where's
So at the moment is West Streeting, obviously.
yeah.
But whoever it is at the time. Um, and I would I would give them the examples around the country where self-care and self-management is working, and say essentially that the move away from the biomedical model, which wasn't working very well, um, it is and the shift to self-care, with absolute examples that are going on across the country. I would that's what I would say. Go and see them and see how we can replicate them not only for chronic pain, but for other chronic conditions, so diabetes, heart disease, mental health. If you are based in the community, getting people to self-care and self-manage, you'll make an absolute major difference to healthcare in this country, and you'll save a packet as well.
Yeah.
So that's one. Second one is Dr. Gabor Mate. Have you heard of?
No.
Oh, right. Oh, really interesting. So he's a Jewish physician in America, and he's looked a lot at trauma, and how that impacts on people physically and mentally. And I got into I read his book, um, which off the top of my head I can't remember. But if you Google it, it's really about complex trauma and how trauma in childhood and early adulthood can impact upon people's lives. I mean, not only from a pain perspective, um, although he does concentrate on that quite a lot, but on obviously mental health, addiction issues, heart disease, etc., etc. So it would just be great to get his viewpoint on what's happening in the world, and the shift from um, again the biomedical model to the biopsychosocial model, and how we can help deal with some of this complex trauma that's happened to help people manage and self-care and self-manage. And the last one is probably there's a surgeon in America called Atul Gawande. He's again um, written a book. I've forgotten the name of it. It's Being Mortal. Being Mortal. That's it. Fantastic book about, as the name suggests, mortality and how we are as humans. Um, and he's a surgeon in America, and he's introduced lots of different ways of working. And I would love to get his take on how self-care and self-management, how we can spread that across the whole healthcare system, but also looking at, and I think he's a public health physician as well, how we can look at embedding self-care, self-management skills eh, before pain happens. Because if pain's 1 in 5 in the population, how do we give people the skills potentially before they become having painful
Yeah.
conditions?
Totally
And
agree.
also how they manage their diabetes and heart disease and
Yeah.
COPD. How do we give them the skills very early on, to manage those? That's what I would do, really.
Yeah.
So those are my three.
Well, great choice.
Wow.
The third one is I've always been banging a drum about getting in quicker, and if we could teach self-management within schools, because most people are going to end up
Yeah,
with some sort of
100%.
long-term condition. So, and that's I mean, I always remember hearing a talk up in Norfolk once, and the lady was talking about how did the recycling revolution started, and she said it all started within the schools, because then the kids were taught about recycling. They went home and
Mm,
they taught the parents and their peers. And I thought I'm sitting there thinking, well, why don't we do that with with long-term conditions, like because that way, because most people at school now will 10, 15 years in the, down the line, they're going to be they may end up with a long-term condition, but they will have learned the basics of self-management, like keeping active,
absolutely. Yeah.
like exercise.
Yeah.
And the second one you
Absolutely the way
mentioned,
forward, I think. Yeah, 100%.
and it's funny you say the second one you mentioned about trauma and stuff like that. I used to do a lot of work with in Germany with a pain doctor friend of mine, Dr. Sittel, Reinhard Sittel. And always remember him saying to me once that he believes a lot of people with long-term pain. He used to run the pain management program in Erlangen, near Nuremberg, and he used to say
Mm,
that he believed that a lot of people with long-term pain, it's something gone on in the past, like and so and you just saying that it
yeah.
sort of plays that out as well, like. Well, it's the same.
Yeah, that's it. That's it. When the When the
Yeah.
Body Says No. That was the name of the book. The Body Says No.
When
When the
nobody
Body
says
Says No.
no. Okay.
Right.
So I think we've come to the end of the time now, and Asim, thanks very much for being our guest tonight. I found
No, thank you so much for having me. Really,
Listen,
really,
man,
really
I'll
interesting.
tell you, as the more we keep doing these Q&As, I'm sitting here saying, oh man, this was ridiculous. I'd love it. I mean, it's just, there's so much information out there, and uh, you know, I think I know we're going to just keep on doing them. And I don't know about you, Dave. I'm just saying I'm feeling about it. I was listening to Linda yesterday, and then I'm thinking, well, God, all this good information we've learned tonight, like for other people to get to learn. I think they're just becoming really this sort of format is going to be. Hopefully, some other people will take on this format and get cracking and do some Q and A's. But anyway, but we're doing it for the time being.
Yeah,
So, Asim, thanks very
brilliant.
much for your
Keep
time.
going, please. Amazing.
Yeah, we'll all keep
No,
going.
no, thank you. Thank you
It's in
so
our
much.
blood. Dave, I'll see you in a minute.
Absolutely.
Asim, take care. Have a nice evening. Ciao.
Thank you.
Guys,
Take
I'll
care, guys. Bye-bye.
upload the video and it'll be ready for hopefully tomorrow. Take care. So, ciao.
Take care. Bye-bye.